Well, it's a pleasure to be with you again and to talk to you about some newer information about imaging in MSA. And the goal of my talk today is really to take you through an understanding of how a neurologist or a clinician may consider imaging in clinical practice, but also how we consider imaging from a research perspective in our effort to try and find better diagnostic markers of MSA and better longitudinal markers of disease progression in MSA. So I'm not going to have too many slides, but I'm really going to talk about the themes of what we're looking at. And hopefully at the end of it, you'll have a better appreciation of how to read about MSA, how to consider clinical trials in MSA, and even how to interpret some of the data that comes out from MSA studies. So to begin with, I just want to show you what an MRI scanner looks like. And if you went to my other session on clinical trials, you might remember this picture, but this is actually the MRI scanner that we use in our center. And this is what it looks like. There are different Tesla magnets in MRIs. The lower Tesla, the lower power, and the higher Tesla, the higher power. And generally, we use 3 Tesla magnets. Those are the ones that get better resolution or how estimating the fidelity of what you're looking at. It's kind of like the difference between looking at a Matisse versus looking at one of those Renaissance painters, which has very fine detail, and where the Matisse is kind of fuzzy, that's low resolution, and some of the kind of more classical painters has very vivid detail, almost looks lifelike. And that's with that higher resolution, you get better pictures of the brain. And so they sometimes do like 7 Tesla imaging, which is extremely high power magnet, and some places are even trying higher. But most of the studies that we use, we really focus on 3 Tesla magnets. Now, of course, with an MRI, it's a magnet. So there are certain risks that we have to take into account. So if you, for instance, have a pacemaker, that's obviously made of metal. It goes in your heart. An MRI scanner may not be the best idea for you. Sometimes they make pacemakers that are compatible with certain scanners. If you've had a brain aneurysm or a clip or some type of metal in your head, we would generally dissuade one from getting a brain scan. A lot of times we get questions about things like gallbladder clips or orthopedic screws or hip replacements, and those are generally okay with MRIs. So there is, not everyone can get an MRI. Most people can, but you may or may not be eligible for an MRI based on your medical history and the procedures that have happened till now. So here's the outline I'm going to go over today. I'm going to just kind of go over some of the main MRI findings. It's certainly not exhaustive, but it's just kind of the main things that you might look for in an MRI. I'm going to talk about an imaging modality that's not MRI, just to show you an example of what MRI doesn't show us, or at least not yet, and then go through some of the main MRI tools that we use in clinical research, all the way from structure to function to chemical composition. So this is an example of a kind of a classic MRI scan in a patient that has multiple systems atrophy. And what you can see here are 3 images. The one on the far left is what we call a sagittal scan, and that's kind of looking at the side of a patient. You can see the nose is here, the mouth is here, the tongue is here, and here's the brain, the cerebellum, and the brainstem. And so if you look carefully at this person, you can see that this cerebellum is quite atrophic or shrunk. So typically the volume would come all the way out here. You'd see grayness, but you see how there's like darkness. And you can see that cerebellum is small or is shrunken. And we call this T1 imaging. It's a type of sequence that we're looking at where the tissue is gray and the cerebral spinal fluid is dark. You can see this is what we call an axial MRI cut. So we're looking at across the brain. You can see the person's lying on the gurney here, and the left ear would be on this side, the right ear would be on this side, and that's the nose. And so what we're looking at here is this cut through the cerebellum. You can see this brainstem area, and there's these little peduncles, or these fiber tracts that go from the cerebellum up to the brainstem, and these are actually atrophic, meaning they're shrunk. And then finally, one of the more common things you see is what's called a hot cross bun sign. And it's just a kind of an artifact or a result of some of the degeneration in the brainstem, that you can see what looks like a crucifix in the brainstem. So in this case of a gentleman that has multiple systems atrophy, cerebellar predominant type, you can see the classical things we might look at would be cerebellar atrophy. There's some brainstem atrophy. There's middle cerebellar peduncle atrophy. There's a hot cross bun sign. And so diagnostically, if a patient comes in and the clinician orders this and sees this, then taken in the context of the patient in front of them, one might come to a diagnosis of MSA. The other things you can see is what's called putamenal atrophy. And this is a concept. So you're going to get a little neuroanatomy class as we look at this, but this is another type of imaging finding that happens in MSA patients. And so the way the deep parts of the brain are structured, there's what's called the striatum, which is made up of the putamen and the caudate. And then there's another part called the globus pallidus, which is kind of in the middle. But you can see in certain patients, especially with MSA parkinsonism phenotype, they can have what's called putamenal atrophy, and they get this what's called slit-like ventricles. You use darkness on the side of the putamen, and that's actually made up of what we call iron. And you can see that darkness here, and we actually get what's called a rim, or a hyperintense rim on the outside of that striatum. And you can use some new methods, which I'll talk about later, that you can actually quantify how much iron is in the striatum. And you can actually see here in the putamen, there is a lot of iron in this patient. And this lady was a patient of mine who initially presented with concerns of Parkinson's disease, but she developed more progressive symptoms at a rate that was a little bit quicker than we'd expect, and didn't have a very good response to levodopa therapy. And we did an MRI and found this, and she also ended up having some ataxia or some cerebellar signs as well. But really the take-home point for this is that you can see diverse findings on MRI in MSA patients, where you can sometimes see cerebellar atrophy, brainstem involvement, and putamen or globus pallidus or striatal involvement. And this is not new. In the old days, so to speak, we still do this now in some of our patients, but we can do what's called a PET scan. And so what I've shown you before in the MRI is structure, and the PET scan looks at, in this case, function, because we use what's called a glucose ligand, and we inject it in the patient's arm, and then the brain uses glucose, and we can see how the brain uses that glucose. And so when the glucose goes to the brain, it lets off a radioactive signal, and we can capture that radioactive signal in the PET scan and link it to where it comes from, and get an assessment of how that function of that part of the brain is working. So in Parkinson's disease, one might see generally a normal looking glucose map. And so you can see that same region I talked about, the putamen. You can see it nice and big. And so red means it's using a lot of glucose. This inside part's the thalamus. There's the caudate. But in a patient with MSA, you'll actually find that their glucose utilization is reduced. And so you might see a patient that has reduced function of that part of the brain. You may not see structural changes necessarily initially, but that part of the brain is not working well. And so that's also useful for potentially diagnostic and also tracking disease progression in patients with MSA. So how do we measure structure? And there's different ways to do it. And I want to just highlight three ways, both kind of to give you some insights into how the revolution of artificial intelligence has taken over a lot of what we do clinically and research-wise, but also to give you a sense for how we are trying to apply new methods to do a better job of characterizing the structural integrity of patients with MSA. So one of the diseases where there is a lot of explosions into research for structure, and that's, how big is a certain part of your brain and what's the volume and thickness and things like that, was Alzheimer's disease. So you can imagine with all these Alzheimer's disease trials that happen, investigators wanted to know how big is the cortex or the outside of the brain, how does that volume or thickness change over time? If you give a medicine, how does that change that outcome measure? And one of the challenges when you're dealing with 20,000 people is that you can't sit there and draw that cortical area by hand. That's a lot of work. And so there have been a lot of kind of mathematical applications from bioengineers, and one of the more common atlases, well, one of the common methods that can be applied to atlases is called FSL. Another one's called Free Surfer. But essentially what these are is you would take a brain and you would put it into an algorithm, and the algorithm would spit out a structural assessment. And so in this case, we've taken a brain here and we put it through this program, and you can see that a computer will spit out a volume of certain structures. So you can see in the top, this is the caudate, this is the putamen, this is the globus pallidus and the thalamus. And so this is the same patient I just showed you that had the putamenal atrophy. And you can see that on this FSL, which was, it's a pretty good atlas. You can see that it does a pretty good job of segmenting of the brain. But you can see on this one over here, this putamen, it kind of goes outside the putamen, so it does do a great job. And one of the things that we've been working on in our lab is finding better ways to define the structures of a patient with MSA, because different things will atrophy in MSA than, say, Alzheimer's disease. And so one of the ways we tried is we create an atlas that's based on very high resolution images. And so when I started, I told you about the difference between 3 Tesla and other higher Tesla scanners. And so we took 20 people that didn't have MSA or didn't have a neurologic disease, and we scanned their brain with a 7 Tesla scan to get very, very high resolution pictures. And we drew the structures of the subcortex in those people. And we were able to take that map and apply it to patients, say, with MSA, and you can see we do a little better job. You can see the putamen here isn't as kind of jutting out as over here. And you can see we do a little better at capturing some of the thalamus and other areas. And then this is the artificial intelligence thing. One of the methods that our colleagues use here is to try and teach a computer how to do a better job of finding the boundaries of structures in the brain. And so this is also called deep learning. And so basically you'll have the computer draw a segment, then an expert clinician will redraw that segment and then run through that program again. And so the computer learns how to handle different situations and different contrasts across borders to get an even better estimation. And this is an example where we conducted a artificial intelligence approach with coming up with better segmentation of MSA, and we ended up finding that it worked even a little better than the multi-atlas. So it's a process that's ever going. And I think one of the goals with teaching a computer how to see differences is that the human eye is okay at seeing, different shades of gray, but the computer can do a much more unbiased job about discerning borders and finding structures. And so using these high-power computers, we're trying to advance the science of MSA research by coming up with better methods to identify structural changes. So that's my kind of MRI spiel on structure. I had tipped my hat to the concept of function when I talked about glucose PET scans, and I told you that structure is important, but learning how a brain functions can also be very useful. And one of the things that is a challenge for PET scans is that you have to make this radioactive tracer and inject it into patients' veins, and then look at the tracer in the brain. And that's a lot of work. It's sort of invasive in that we have to use radioactivity. The resolution isn't as good. It's again looking like a Matisse painting and not a Vermeer. And there are some challenges in interpreting. So a lot of research has gone on in terms of how can we look at function without having to use radioactive isotopes. And one of the ways we can do that is look at what's called blood flow. And I think this is a really interesting idea. And this is the concept that if my brain's working a lot, I require more oxygen or more blood to that part of the brain. If it's not working well, I require less oxygen or less blood. And so there are ways that you can actually map blood flow in the brain. Essentially, what you do is when you lie in an MRI scanner, the water molecules in your body conform to the vector of the magnet that you lie in, and you're able to pulse those water molecules, say in the blood vessels of the neck, the opposite way, and then record if they reverted back to their normal orientation or not in the brain. And you're able to use some complicated mathematics to get an estimate for how much blood is flowing to how much tissue. And so we get this outcome measure of cerebral blood flow, which is a measure of milliliters per 100 grams of tissue per minute. And so you're able to say, look at a person that doesn't have MSA, we call them a control as a comparator. You can see that there's a distribution of blood flow that where it's red, it's a little bit higher, and when it's green, it's a little bit lower, and it kind of fits similarly to that picture that I showed you of the fluorodeoxyglucose PET scan. It's not radioactive, it's not invasive. You just lie in an MRI scanner. And one of the things we've done recently is look at how patients that have autonomic dysfunction, how does their blood flow map look? And when we started this, we thought it'd be very low. We thought that it would be kind of like the FDG PET studies where it'd be low, suggestive of metabolic derangements to the brain. And what we found in surprise with this, there's a very marked compensatory increase in cerebral blood flow in these patients. And you can see here, the red is high, and this is much higher than you would see in a control patient. And it's led us to ask some really interesting questions about how does oxygen get to the brain in MSA? How efficient is the brain in extracting oxygen? How can we understand these dynamics as we try and figure out what predicts progression in MSA, or even therapies to improve oxygen exchange to improve brain function? But that's another MRI tool that you may come across. It's called arterial spin labeling, and it's really looking at blood flow and blood volume and blood transit in the brain. And earlier I told you about the iron signal that happens in MSA, especially in the putamen and pallidus of MSA-P patients. And I want to tell you a little bit about iron and how we can understand it in the brain, because I think you might find this interesting. And at least with one of the studies that I'm working on, we're trying to come up with an iron chaperone medication that takes away labile free iron. So iron, as you remember from your 8th grade science class, is a paramagnetic structure. And so you can imagine that if you're being put into a scanner, you can use the advantage of that paramagnetic structure to actually see where the iron is based on how it emits a signal when you expose it to uh, a magnet signal. And so one of the interesting things that we're seeing now is that where the iron is and how much is there directly relates not only to the diagnosis of MSA, but also the severity of symptoms. And so in this top row, you can see a sagittal, a coronal, that's head-on, and an axial image. And where the dots are, that's where there's higher iron. And so in a patient that has MSA versus patients who do not have MSA or control comparator groups, you can see that in MSA patients have higher iron in the cerebellum, higher iron in the putamen, and higher iron in the globus pallidus. And that's been a very interesting finding for us as we've gone to try and explore some of the features that make MSA different from Parkinson's. And we show that here in the bottom, where we take a group of patients with Parkinson's and a group of patients with MSA, and we do that same comparison. We see that MSA patients have higher iron in the cerebellum, higher iron in the putamen, higher iron in the globus pallidus. And of course, the question is, what's the iron doing there? Is it part of the pathogenesis? Is it part of the disease? Is it a byproduct of the disease? Is it just an incidental finding? And so that's one of the big outstanding questions in MSA. And hopefully, if we have trials that can modify the iron and test whether or not changing the iron changes the progression of the patient, we'll be able to answer in part that question. Importantly, the question would be, it's present in MSA, but is it related to symptoms? And one of the studies that we did is we looked at how severe a patient's MSA is and looked at where the iron relates to that. And what you see in this diagram is that the higher the iron, the higher the disease severity of a patient with MSA. So at least it tells us that there's some relationship. It may not be causal, or it could be associative, obviously, but it tells us that iron is at least tracking with the disease symptoms of a patient, and that's useful as we think about medications that may alter iron or change the biology of MSA, to use this as an outcome measure of that disease. Another newer MRI sequence that we are working on is called Neuromelanin. So in the brain, there is melanin, which is a chemical that we think of in their skin. So if you have really dark skin, you have more melanin than if you have light skin. And so you'll think of as someone who's maybe an albino, they have like no melanin, their eyes are red, their skin is very white, and they have white hair. So that would be an absence of melanin. But actually in the brain, there is melanin. And what it does there is it's not entirely clear. It probably has something to do with being a reservoir for waste, maybe, or for metals. It may do other things. It may be there as a byproduct of dopamine or monoamine synthesis. But there are two really big places that that melanin lives, and one is the substantia nigra, which is over here. So this is another axial image of an MRI. There are the eyeballs, there's the nose. You see that kind of whiteness in the brainstem, that's melanin. And that area generally localizes to the substantia nigra, which is part of the brain that makes dopamine. And so you may have read about that when you've come across reports of Parkinson's disease, where melanin, in autopsy, a patient with Parkinson's disease will have no melanin. But of course, you don't want to assess these in autopsies. You want to assess them in real life. The other place that makes melanin is called the locus ceruleus, which is a place that makes norepinephrine. And that monoamine is obviously important for blood pressure regulation, alertness, probably memory as well. And that's another melanin-containing area. And so we and others have developed methods to quantify or measure how much melanin is in the substantia nigra and how much melanin is present in the locus coeruleus. And so we can do what's called a contrast ratio, and I'll show you how we do this, of these areas to kind of estimate for how robust is that melanin in that area. And so this is how we do it. So we'll take, this is like a really close-up view. You can see as you get more close up, you can see the voxels get a little bigger, and this is that resolution thing I'm talking about. But you can actually say, okay, I know that this is the substantia nigra, and I know that this isn't. So I want to know the relationship between this to this, between the blue to the green, or between the pink to the red. And that gives me a contrast ratio. And where it's lower, it means that there's less neuromelanin. When it's higher, there's more neuromelanin. And so we've recently used this method in multiple systems atrophy patients to see, can we come up with another imaging method to diagnose the severity and the presence of MSA. And here's some of our findings in a cohort of about 20 or so patients. And where you see redness, you can see that there's lower neuromelanin and higher disease severity. And what's interesting to me as a neurologist is that you see it on both sides of the brain, which is always very important when you do these imaging studies. Sometimes if it's only one side, you don't know if it's an artifact or if it's kind of a spurious finding. When you see it symmetrically, you kind of feel a little bit more convinced that it's related. But what we find here is that the lower the contrast of neuromelanin in the substantia nigra, the worse the symptoms. And so we're trying to develop these methods to apply to multiple sites and multiple patients to see how disease-modifying therapy may or may not modify the contrast of neuromelanin to get a signal of whether or not we're maintaining neuronal viability as a marker of the therapy that we're trying. So with that brief summary, I think hopefully at the end of it, you've got a little appreciation for how MRI is used from a diagnostic standpoint in the conventional measures like structure. You've been able to compare what the data that we get from an MRI to, say, a PET scan, and you've been at least introduced to newer methods for MRI, which include assessments of blood flow, assessments of neuromelanin contrast, assessments of iron, and new ways that we can kind of quantitate structural methods through things like artificial intelligence. So I hope that was useful for you and gives you a picture of where some of the exciting new things for MSA research and in clinical studies. And so with that, I thank you, and I hope this was beneficial, and we'll talk soon. Thank you.
Hello, welcome everybody. I'm Gregor Wenning from Innsbruck, and it's my pleasure to talk to you about the clinical diagnosis of MSA, presenting the new diagnostic criteria developed by the Movement Disorder Society. These were published earlier this year in the Movement Disorder Journal. The reason why these new criteria were developed was that the currently used criteria, the second consensus criteria for MSA, have a poor sensitivity. Only 18% of patients diagnosed with probable MSA, or 41% of patients diagnosed with possible MSA, are actually picked up at first neurological visit. So most patients with MSA are not clinically diagnosed as such. The other issue is that the accuracy of an MSA diagnosis is likewise poor. This has been shown in clinical pathological studies, one by Koga and colleagues, and the other one by Mickey and colleagues, demonstrating accuracy rates of 60 to 80% only, confirmation at postmortem of the clinical diagnosis of MSA. And there were a lot of other diseases present at postmortem mimicking a clinical MSA diagnosis. So these were the reasons why people at the Movement Disorder Society decided to convene a criteria revision task force. This was 4 years ago, and I had the honor to chair this task force together with Horatio Kaufman. In total, there were about 40 people involved in this effort. Iva Stankovic was a great coordinator, leading a junior executive team in this effort. The methodology of revising the current criteria was evidence-based. A lot of literature searches were performed on MSA criteria and diagnosis, and that presented the evidence basis for the task force to move on. At the same time, we had consensus methodology in this project, 2 Delphi rounds, a survey to the entire Movement Disorder Society membership, and a final virtual consensus conference due to the Corona crisis in 2021 to arrive at the new MDS MSA criteria. Now, this is just a broad representation of the categories of the criteria that are currently used. The second consensus criteria define neuropathologically established MSA, definite MSA, and clinically probable as well as clinically possible MSA. The new criteria are pretty much the same, but in addition, they add a category of possible prodromal MSA to catch patients early on in the disease. These are research criteria, and I'm going to present them to you. Another change compared to the previous criteria is that patients would like to know for sure that they have MSA, and therefore we avoid or we change the concept to clinically established MSA. These are patients in whom the clinician is pretty much certain that MSA is present. And that's separate from clinically probable MSA, where the certainty is less. Now, let me illustrate to you the core clinical features that are part of the criteria. Autonomic failure is a very distinctive feature, and this lady here from Serbia has very severe cardiovascular autonomic failure with a substantial drop of blood pressure upon standing. This is her after 3 minutes standing. She's complaining about coat hanger ache and other features of orthostatic intolerance. And soon after, she collapses into the bed and she loses consciousness for a brief period, few seconds. And the blood pressure drops down from 95 systolic to about 61 systolic here. So a very profound symptomatic orthostatic hypotension present in this lady. So this is a very characteristic feature. Another characteristic feature is progressive parkinsonism unresponsive to levodopa associated with postural instability, as shown in this patient, again from Serbia, from Iva Stankovic group, with a visible gait unsteadiness here 2 years after disease onset, and this is 3.5 years after symptom onset, showing progressive gait unsteadiness associated with Parkinsonism, in this instance associated with levodopa unresponsiveness. The ultimate clinical core feature is the cerebellar syndrome, which is present in this patient who reports also emotional lability or incontinence. He starts crying for no good reason. From the speech, you can appreciate this cerebellar type dysarthria, scanning dysarthria, and there's incoordination of repetitive movements as shown here. This patient had very little Parkinsonian features. It was predominant cerebellar MSA, also known as MSAC. So this is the cerebellar syndrome that is present in some, but not all, MSA patients. Now, this is the most important slide illustrating to you the new MDS criteria for clinically established and clinically probable MSA. It's defined as a sporadic, progressive, adult-onset disease after the age of 30, and clinically established MSA is characterized by obligatory autonomic dysfunction and at least one of poorly levodopa-responsive parkinsonism or cerebellar ataxia. Autonomic dysfunction in established MSA is defined as voiding difficulties with a post-void residual of more than 100 milliliters. There could also be urinary urge incontinence and or neurogenic orthostatic hypotension, as shown in the video clip, with a blood pressure drop of more than 20/10 millimeter mercury within 3 minutes of standing or head-up tilt. The diagnosis here needs to be supported by motor or non-motor features, supportive features, also known as red flags. There need to be at least 2 of them, and I'm going to illustrate all of them in some video clips to come. On the right side, you can see clinically probable MSA, which is diagnosed or defined by at least 2 of autonomic dysfunction, parkinsonism, or cerebellar syndrome or cerebellar ataxia. Autonomic dysfunction is not obligatory. Some patients with probable MSA may just have motor features, including parkinsonism and cerebellar syndrome. Autonomic dysfunction here is defined as voiding difficulties and post-void residual volume. It's not obligatory more than 100 mils after micturition, could be less also. Urinary urge incontinence is part of the autonomic dysfunction, and neurogenic OH, again defined as blood pressure drop of 20/10 millimeter mercury within of 10 minutes of standing or head-up tilt. So we include delayed forms or types of OH after 3 minutes of postural challenge as well in this category. These patients here need to have at least 1 red flag, either motor or non-motor. MRI markers are also of some importance, particularly in clinically established MSA. There needs to be at least 1 alteration on MRI that is typical for MSA, and I'm going to show that later on, whereas for probable MSA, MRI is not required. Then there is a list of exclusion criteria that need to be absent, and I'm going to show them to you later. Consistent with the previous criteria, patients are subdivided into MSA-P if Parkinson's predominates, or MSA-C if cerebellar ataxia predominates. This slide now shows you supportive clinical motor features or motor red flags, including craniocervical dystonia, as shown on the left side in this short video clip. These lower facial and neck dystonic contractures can be induced or exacerbated by levodopa, and usually they occur in the absence of limb dyskinesia. Latter are more characteristic of Parkinson's disease. In the second slide or video clip, you can see jerky myoclonic postural tremor present in a patient with MSA-P. That's also characteristic. Rest tremor is much less common. And then on the right side, you see different types of postural deformities that are characteristic of MSA as well. Anticollis, lateral flexion of the trunk, and contractures of the hands. Additional motor red flags include rapid progression within 3 years of motor onset that we have seen in the video of that young man with MSA-P, moderate or severe postural instability within 3 years of motor onset, severe speech impairment, severe dysphagia, and unexplained pyramidal signs. All of these are characteristic of MSA. They may not be very sensitive, but if present, they are very suggestive. Now, these are supportive non-motor red flags, including stridor. This is a patient from Neil Quinn in London. The stridor is pretty audible here, and due to laryngeal dysfunction resulting in vocal cord, abnormal vocal cord closure, as seen here in the laryngoscopy of this patient. So that is very distinctive. And the association of ataxia or Parkinson's plus that type of stridor is almost diagnostic of MSA. Some patients may also have inspiratory sighs, as this lady has. And that's also typically seen in these patients. And also cold, discolored hands. The cold hand sign sometimes also occurs in the feet and reflects autonomic denervation of the extremities. Another two of these non-motor features include erectile dysfunction in men below the age of 60 and pathologic laughter or crying that was reported by the Serbian patient with MSAC in the video clip, for example. Now, this slide lists the MRI markers. One of these abnormalities needs to be present for a diagnosis of established MSA, so that requires MRI. Could be atrophy in different regions of the brain that are involved in MSA, particularly including the putamen, the middle cerebellar peduncle, MCP, and pons, as well as the cerebellum. There could also be the hot cross bun sign, which is present in 30% of patients with MSA, particularly of the cerebellar type. And there is also increased diffusivity in the putamen and the middle cerebellar peduncle, as shown here in some of the representative MR images. Now, the exclusion criteria, and I don't want to go through all of them, have been drawn up to make sure that Parkinson's disease, dementia with Lewy bodies, and PSP are excluded because they can be sometimes mimic MSA. MRI suggestive of an alternative diagnosis, including PSP, multiple sclerosis, vascular Parkinsonism, or symptomatic cerebellar disease is also important. And then MSA lookalikes. These could be other degenerative diseases, including genetic or symptomatic causes of ataxia and Parkinsonism, known to produce autonomic failure, ataxia, or Parkinsonism, and plausibly connected to the patient symptoms. These are all exclusion criteria. Now I'm coming to the research criteria for possible prodromal MSA. This category has been introduced as a research category because it needs to be validated in future research. This is just a preliminary suggestion. Essential features include that this should be a sporadic disease, progressive disease, and adult onset after the age of 30 years, and at least one of the entry criteria needs to be present. This could either be a REM sleep behavior disorder. This is violent dreams with acting out, motor enactment, and proven by polysomnography. This is often connected to future development of MSA. The other non-motor presentation could be neurogenic OH, as occurs in pure autonomic failure, with a blood pressure drop again of at least 20 over 10 millimeter mercury, within 10 minutes of standing or head-up tilt. And the third non-motor presentation could be urogenital failure, including erectile dysfunction starting below the age of 60 years, associated with voiding difficulties and a post-void residual volume of more than 100 milliliters and or urinary urge incontinence. And these non-motor features need to be associated with a certain subtle degree of motor involvement, including subtle Parkinsonian signs and subtle cerebellar signs. So in the absence of these motor signs, it's still going to be impossible to presume that this is possible prodromal MSA. It could also be Parkinson's disease or something else. Exclusion criteria for possible prodromal MSA include unexplained anosmia on olfactory testing, which is very typical for Parkinson's disease, or abnormal cardiac MIBG scintigraphy indicating sympathetic cardiac denervation, which again is more suggestive of Parkinson's disease or Lewy body disease in general. Clinical features suggestive of dementia with Lewy bodies or PSP, or an alternative diagnosis based on brain MRI, or a documentation of MSA lookalike conditions, same as for clinically established or clinically probable MSA, are also exclusion criteria. So these criteria serve to highlight the early stages of potential prodromal MSA, and it remains to be seen whether they are useful for research and clinical practice. Now, there is also a list of biomarkers that are not formally part of these criteria because the evidence base was not conclusive, but they may be suggestive of the disease, and they need to be studied further in research projects. And these include FDG PET, which indicates brain regions that have poor metabolism, and in MSAP that includes putamen, brainstem areas, and cerebellum, and for MSAC that includes hypometabolism of the putamen. Other markers include normal MIBG scintigraphy, indicating intact sympathetic innervation of a heart muscle, polysomnography proven RBD, a supine plasma norepinephrine level that exceeds 100 picogram per milliliter and is associated with orthostatic hypotension, urodynamic testing that reveals detrusor hyperactivity or detrusor sphincter dysynergia. An abnormal sphincter EMG is also often consistent with the diagnosis of MSA, as well as wet biomarkers, including alpha-synuclein oligomers in CSF or neurofilament light chain in CSF and plasma. There is also a list of supportive biomarkers for possible prodromal MSA, and that again includes MRI alterations similar to the ones that I have shown to you already. Also, FDG PET with hypometabolism in putamen, brainstem, and cerebellum. Again, supine plasma norepinephrine levels greater than 100 picogram per milliliter associated with neurogenic OH. Urodynamic testing showing detrusor hyperactivity or detrusor sphincter dysynergia, or an abnormal sphincter EMG, or wet biomarkers including alpha-synuclein oligomers in CSF or neurofilament light chain in CSF or plasma. As mentioned before, all these biomarkers are potentially interesting, but they have only been reported in single cohort studies. So more data are required to really establish them more firmly in the currently proposed MDS MSA diagnostic criteria. And with that, I would like to thank you for your attention, and I hope that I was able to show you the future direction for research and clinical practice in MSA clinical diagnosis. Thank you.